about 3 leads. Did you guys do um, labs yet for 3 leads? You are allowed to unmute, I promise. I know you all have voices. And please, like, during like the lecture, if you have questions, like, please, like, shout up, like, interrupt me. I don't care. Like, that doesn't bother me. Um, Someone speak up for Danielle because her mic doesn't work. But like, give me a heads up if like I'm moving too fast or if there's something that you're like, hi, quick question, timeout. Okay. Um, so I guess we'll just start. I'll just let me know. Okay. Cool. Um, oh my goodness, there's so many things going on. Okay. So 12 leads, right? The most important thing, hold on. Let me make this go away. Can you see what I'm seeing? Yes. All right. So in regards to 12 leads, the first thing that you really, like, we talk about placement and stuff like that, the first thing that you really kind of need to understand is that you need to know what your underlying rhythm is, okay, regardless. So if it's a sinus rhythm, it's a sinus rhythm, but you're kind of expanding upon the information that you're getting because you are looking at the heart from more angles. So when we talk about 12 lead monitoring, you have the limb leads, and then you have V1 through V6. So V1 is the only lead that's on the right side of the sternum, okay, and it looks at like the right wall of the heart. And we're going to talk about each placement a little bit, but it also gives you a lot of other information, such as if there's a bundle branch block, what the electrical axis of the heart is, which can give you a lot of information regarding if it's going to be a VTAC or if it's like SVT with aberrancy. And what we primarily use it for in the field is to determine if the patient is having a STEMI or not. And I know one of you guys had a nice STEMI yesterday. Julia had a really nice STEMI yesterday, so if she wants to share that with the group, I don't know if you guys have a group me or whatever, or if you've already done that. It's a nice example of getting a really good picture of what is going on electrically in the heart. Now, quick recap, just because you have electrical movement in the heart does not mean that you have mechanical movement of the heart, right? So just because there's electric moving through it doesn't mean that it's going thump, 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 right? So you can electrocute a hamburger as much as you want, but it's not going to ever pump blood. Moving on to next slide. There we go. So whereas your 3 leads kind of look at across the heart, the precordial leads or your chest leads are looking directly at the heart. So if you look at the picture on the right, you're just looking directly at the heart itself. Okay, so V1 and through V6 look at different parts, starting from the right side or the septum really, and a little bit on the right, to all the way around to the left side of the heart. So when your heart sits in your chest, it doesn't sit like left and right. It kind of sits with the left ventricle facing forward, okay? So when you're putting your chest leads on, you're really getting a really good look at that left ventricle of the heart, which is really the powerhouse of the heart. If the right atrium and right ventricle aren't working fantastic, you're gonna have some issues when it comes to like fluid buildup in the lungs. But if the left ventricle and atrium is not that important, but it's important. If the left ventricle isn't pumping effectively, that means that you're not getting blood to the rest of your body. So this is why patients who are like altered mental status, you really always should be doing a 12 lead on to make sure that they are getting a good blood flow, as well as obviously getting blood pressure, etc. So one of the things that you can kind of determine, or absolutely determine, when you're looking at a 12 lead is what the electrical vector of the heart is. So if anyone, I think it was his physics, right? You basically, a vector is the different ways that electric can move in the heart, right? But the axis is the culmination of the most electric in the direction in which it's moving. So because the left ventricle is so much larger than other parts of the heart, it's kind of going to pull the majority of the electric away. So, you know, if you kind of get what I'm saying. So let me see if I can doodle for you. Give me a doodle. Doodle. Maybe. All right. So, right. So we know that you have that didn't doodle at all. I know I can annotate, but give me a pen. Maybe. No. All right. We're going to see what happens. Come on, give me. All right. I don't know what's going on. So you have your electrical axis here, right? Up in, I don't know if you guys can see the pointer. Can we see my pointer? Anybody? Bueller? Okay. There it is. Aha. Come on. Do something productive for me, computer. That didn't help at all. All right. F it. So, now it works. So you have the electrical that starts up here in the right atrium, right? You have your SA node. And the electric moves across here, down here, and then down into the, we're going to put it over here, the AV node, before it moves down and around in both directions. So because your right ventricle is kind of on the skinnier side, all right, so if you kind of think of the left ventricle as sort of like the bodybuilder of the heart, and the right ventricle is sort of like that really skinny Kenyan runner, you're going to have more electric moving through more muscle mass here on the left ventricle. So it skews your electrical axis into this side of this diagram. So a normal EKG, and you'll see on the top of like a 12 lead, it will actually tell you what the electrical axis is. A normal 12 lead should have a axis between -30 and +90. Okay, if you don't have that, if it's anywhere else, if it's in between another range, like on this side over here, it could be because either there's a bundle branch block or because there's dead tissue that isn't transmitting electric, right? So if you're not transmitting electric and the axis is skewed, that could indicate that even though you don't see a patient with ST elevations, that they are having some sort of cardiac event. It also could be an older cardiac event because of the dead tissue overall. All right, clear. Sorry, I'm used to using Zoom, and the Zoom is, their annotation is less obnoxious. Go away. Nope. All right, cool. So now if you have a patient who has what's considered a left axis deviation, okay, this means that they're in leads, let me backtrack, sorry. To determine an axis, you're going to be looking at leads 1 and AVF, okay? So this can be done without a 12 lead, but it's usually helpful when looking at a 12 lead to determine what's going on. So you're going to be looking at leads 1 and AVF. In a normal 12 lead, your leads 1 and AVF are going to have positive deflections, okay? So both the QRS complexes in both of those leads should be positive, okay? Or upward facing. If you have a patient who has a left axis deviation, lead 1 is going to be facing up while AVF is going down, okay, right? So when you're looking at the bottom of the heart, right? So AVF, you're kind of looking up as if you're looking from the feet up into the heart. The electric is going to come down at you and then away, which is not normal. Usually it should be just going away from you, okay? If this is what you're seeing, there's a number of different things that it could mean. So, for example, the left ventricle could be extremely large, right? So it's pulling more electric towards that left ventricle without being balanced, as you know, it's always an unequal balance, but it's even less balanced now that the right ventricle is substantially smaller than the right. Or sorry, the right ventricle is substantially smaller than the left. So you have this big left ventricle that's kind of skewing that axis up towards that left side. It's very common in patients who are very obese or pregnant, okay? Because if you think about it, what happens is as that weight or the weight of the baby starts to kind of fill in the abdomen, it actually will push the heart up, especially in pregnant patients, okay? So now think about it, right? You're growing this small human creature thing, and as it starts to take up space inside of the abdominal cavity, it starts to kind of displace those organs. I saw a really funny meme once. This woman was saying, like, I don't know where your organs go when you're pregnant. Like, you just carry them in a handbag. No, they move upwards. Or downwards if it's a bladder, because this is why pregnant women pee all the time. So as those abdominal organs get kind of displaced upward, the heart gets displaced as well, as do the lungs. Everything kind of gets smooshed up. So the heart actually will kind of shift, okay? So it will actually kind of swing, because your heart, kind of in a really cool fashion, is actually just suspended in your chest from your aorta and a few ligaments, okay? So it's just kind of chilling, hanging out there. So it moves. Even as your heart moves and starts beating regularly, it actually swings back and forth in your chest, which is kind of just one of those really cool. This is why it's surrounded by pericardial fluid, because there's friction and momentum. So in the event that the heart is starting to be moved, which also can be moved in the event of a pneumothorax, right? As that air starts to fill up the chest cavity and starts to push the heart, you'll see that this axis deviation will start to kind of show itself on the EKG. Other things that can cause this, left bundle branch block, right? So if the electric is delayed and it starts to move the slow route as opposed to the fast route, which we'll talk about when we get to bundle branch blocks, you might see a left axis deviation. Anything that's going to kind of change the way that the heart normally receives its electric, such as like a pacemaker, can change your axis. Now, going in the other direction, you have a right axis deviation. Okay, so it's down on this other side. This is usually indicative that the right ventricle is way bigger than it otherwise should be, right? It should be a skinny Kenyan who can do a marathon in like 2 hours. It shouldn't be this massive, bulky bodybuilder like the left ventricle. So if all of a sudden the right ventricle starts to do bulking season, then you're kind of like, it's pulling more electric because there's more muscle cells that it needs to depolarize. So this is really very frequently seen in patients who either have a pulmonary issue, right? Because if pulmonary hypertension, pulmonary embolisms, something where the right side of the heart has to pump against a lot of pressure, you'll start to see the building of that muscle. Other things that you might see it is if, again, left-sided tension pneumo, right, as it starts to push the heart in the wrong direction. But in kids, this is completely normal, okay? Or really, really thin individuals, like young adults. Just because you can see through a thin chest wall really well on an EKG that you can't see with like a larger individual, okay? All that tissue kind of blunts how much electric you can see. Any questions? Sidebar, if you are looking at the EKG, if you are looking in lead 1 and AVF, lead 1 will be a negative deflection and AVF will be a positive deflection if your patient has a right axis deviation. Questions, anybody? So this is what a normal 12 lead should look like. Your QRSs should kind of follow the same progression, right? They should be cute and tight and skinny and moving kind of the same way. All right. So as you see, and we're just going to focus right now on the, see if I get the annotation back. Focusing on the precordial leads. Let's use this color, right? So looking at this half of the EKG, you're going to see what they call R wave progression, okay? And you're going to see this pop up on the top of your EKG every once in a while when you're doing a 12 lead. It's going to be like, poor R wave progression, and you'll be like, I don't know what that means. So as you're moving through your EKG, so hold on, so here's your heart. Cute, super, right? So you have V1, V2, oh, nope, V2, V3, V4, V5, and V6, okay? Just now it looks like a weird bumper sticker. So as you're moving around, right, the electricity starts to change because the way that it moves is like, I don't know what happened, is down and around, okay? Right, so here's your septum down in the middle, and then right ventricle, left ventricle. So as you start to change your view, so if you're here at V1, kind of looking at the septum this way, the majority of the electric is moving away from you, right? So you have it moving down and away from you. Same thing with V2, right? So as your position, as your visual position changes as you move around the heart, it's going to go from negative to positive. So what you usually see is that V1 and V2 are both negative deflections. V3 and V4 are both ways, are bidirectional deflections, right? So you have a little bit positive, a little bit negative. And then V5 and V6 are primarily positive deflections, okay? And this is, as you move through time, time is horizontal. This was, so right, as you move through time this way, this is beginning to end, but if you look up and down, this is all the same moment in time, okay? Because I know some people have a hard time conceptualizing that. So leads 1, 2, and 3, this 3-second picture is happening at the same time. You're just looking at different visuals of it, okay? So now looking at your limb leads, you should have the majority of your limb leads should all be positive deflections, okay? Just in the nature of the way that they're set up. V3 can occasionally be bidirectional, as you see right here. Sometimes AVL will also have something a little bit up, a little bit down, just depending on your normal variance, okay? The only lead that's going to be a negative deflection, and should always be a negative deflection, is AVR. So AVR looks at your aorta, okay? So if you have something funky looking in AVR, you should highly suspect that there's something weird going on with the aorta, the aortic valve, a dissection, something to that effect, okay? So your index of suspicion should increase significantly. We understand that? You understand that what's going on with that? Yes, no, maybe so. All right, I think this is the eraser. No promises. Okay. Now, bundle branch blocks. So what you have to understand is that as the electric moves down the septum, it has two routes with which it can go. All right, one to the left, and well, we're going to simplify it. It's got a couple other routes because there's other things in there, but we're just going to focus on bundle branch blocks. It's got two bundles, the right bundle and the left bundle. Also, I'm impressed I got my right and left correct on the first time. So as you're moving down, these are like, think of it like the expressway. Okay, so as you're moving down the expressway, right, you have the expressway and then you have the service road. The expressway, you don't stop. There's no lights. There's no, turns. There's nobody doing something stupid on the side road. You're just going. You're going 70 miles an hour and you're going to get to where you need to go, right? So as long as the electric is moving down these bundles, they are going to go 70 miles an hour, right? It's going to be the normal speed. Now, let me see if I got the annotation back. Don't fail me now, annotation. Now, if for some reason something has created a block, okay, it could be an intermittent block, it could be that perhaps this individual had some sort of cardiac event that has now, kind of killed off this part of the tissue in the heart, it's not going to be able to access the roadway. Okay, so imagine it's construction, right? So now all of a sudden we've decided, hey, it's, 7 o'clock in the morning on the expressway and we are going to do construction, or there was a fatal accident and we had to shut the whole major expressway down, right? So now this fast path is no longer accessible to you. The really cool thing about cardiac heart muscles, don't make fun of my drawings, is that they have like these interwoven channels, right? So, son of a mother. All right, so they have these interwoven channels, right? They're interlocked. So if one cardiac cell gets depolarized, it will transmit that electricity to the next cardiac cell and on until all of the cells have been depolarized. So this is kind of the idea that you're taking the service road, okay? It's slow. It's like doing the wave in a stadium, right? One person stands up and is depolarized, and then the person next to them goes, next to them, and on until it comes back. So what happens is as the right ventricle is doing this slow expressway, slow service road route, the left side of the heart is still taking the expressway, okay? So the left side of the heart's going to be done depolarizing before everybody else on the right side is. So what happens is you get what's kind of the right bundle branch block look, which is like a little on the slurred drunk side, okay? So as you look at the 12 lead, what you need to look at is going to be leads V1 and V6. So in lead V1, you're going to have what they call like bunny ears, okay? So the bunny ears is that the electricity is going really quickly, right? It's going really quick through the left ventricle, and then it's going really slowly through the right ventricle, right? So you have a quick left depolarization, a slow right depolarization. So you can see the slow progression of the electric through the bunny ears. Now, in V6, you get what they call a broad, deep S wave, or a slurred S wave, or as I like to call it, go home you're drunk S wave. So basically, it's the same thing that you're seeing here, but this is the right ventricle doing this slow depolarization, finally getting to the point where you're hitting repolarization, okay? It's very distinctive, and you're kind of going to see the first time you see this really broad looking QRS, your first thought should be probably a bundle branch, okay? Questions on this before we go to move on? So here we are in a larger capacity. This is what a right bundle branch block can look like on an EKG. So you have, turn the annotation back on. You have here, you have your bunny ears, right? And then down here you have this broad S wave, okay? And then if you look right here, remember I said it will give you your axis. Here's your axis, right? So let's look. Lead 1, okay, is upright. So it's not this one, and it's not this one. And now lead AVF is also upright. So it still falls here in the normal, okay? If you have one of these bidirectional QRSs, right, so you have a little bit above the isoelectric line, a little bit below the isoelectric line, basically what happens is you subtract, right? So if you have more above, it's a positive deflection. If you have more below, it's considered a negative deflection. If it's about equal, you consider it sort of normal. Okay. Thoughts, questions, concerns? All right. So, whereas in your right bundle branch block, the right side was affected by some sort of cardiac event, on the left bundle branch block, the left bundle is being affected, okay? So the electric is moving very slowly through a very large mass of muscle in comparison to the right side. So you're going to have very bizarre, very dramatic looking EKGs. Okay, your QRSs are going to be really broad. They're going to be funky looking. The first time you're going to be like, oh, is that a PVC? And they're like, oh, no, there's too many of them for that to be a PVC. Oh, they happen to be preceded by a P wave, right? So, some annotation here. Right, so you'll see in the 12 lead you'll have a P wave, but then you're going to have these funky looking QRSs. Again, you want to look primarily in V1 and V6 to confirm your bundle branch block diagnosis. You're going to have in V1 a really, what's called a deep S wave, right? So it's just really big, really long. It might actually be a little pinched on the bottom or squiggly on the bottom, sort of like you see here. It might also have that down here, but usually it's nice and smooth. And then in V6, it's going to be upright, and it's going to have that V shape. Now, remember we talked about the R wave progression. Hold on, go back to see how it still maintains that normal V wave progression where it's like negative, where V3 and V4 are not as biphasic, right? They're just going in one direction or the other. Okay, that's because of that altered electrical pattern. Okay, so remember here these cells are going from cell. This annotation thing really does not like me today. It's going from cell to cell to cell to transmit that electrical impulse across. Now, see, this is what I mean by large, bizarre. Sometimes the EKG, the QRSs in a left bundle branch block are going to be so big that they actually don't even fit on the EKG paper. So this is some of the examples of what you might see, okay? Now, what's also really important to understand in a left bundle branch block is that your QRS and your T wave are always going to be going in opposite directions, okay? So here on, give me my annotation. So here you see, right, you have your QRS is going this way, and your T wave is going the opposite direction. In the event that you have, like, because in our normal EKG, the QRS and the T wave move the same way. If you happen to have an individual who has a QRS and a T wave going the same direction in a left bundle branch block, you should be suspicious that that individual is having an MI. Okay? And we'll talk about Sgarbossa criteria a little bit later. But also, so now let's look at your axis, right? So V1, or lead 1, not V1, sorry, is positive. So that means it's not this one, and it's not this one. AVF is negative, right? So that gives you that clue that it's going to be over here in the left axis, that the electric is being altered. I'm going to fight this annotation thing later. All right. So, hold on. I see, Aaron, you're lost. So your axis will be printed out. I don't know many medics who actually look at what the axis is. If you wanted to determine your axis, you're going to look at leads 1, which is, hold on, let me get the annotation back. You're going to look at lead 1 and lead AVF, okay? A normal axis is down here in this corner, okay? So lead 1 will be a positive, will be a, for the love of God, lead 1 will be positive, an upward deflection, and lead AVF will also be an upward deflection, okay? In the event that that doesn't happen, I haven't figured out this annotation thing at all, you're going to look at these other axes. Don't harp too much on axes. You will probably not see them on any test in the near future. It is something that we teach you so that you can determine the difference between a VTAC and an SVT later on when you're doing like patient care, okay? Because that's going to kind of determine how what you do. Like if you're going to be, you know, cardiac synchronized defibrillator, oh my lord, synchronized cardioversion, or if you can be using adenosine, okay? So basically, just if you keep this in mind as we move on, it's really the only time you're really going to apply it. But basically, when you're looking at an EKG, if lead 1 is up and lead AVF is up, it's normal. If it's not, there's probably a bundle branch or something else going on. I think that's the easiest place to leave it. Does that clear it up a little bit? Like it's not something you really have to go heavy on. Yay? Nay? Leads 1, 2, and 3. V1 or lead 1? Ah, we're not there yet. I will get to there. That's like a few more slides. Hold on. Let's just skip to that slide. Maybe. Oh, fuckery. All right. This, yeah, cardiac locations. So when you're looking at your EKG, each lead is looking at a different part of the heart. So if you are looking at leads 1, 2, and 3, lead 1 looks at the lateral wall, while leads 2 and 3 look at the inferior wall. Well, let me draw a really crappy picture of a heart so we can maybe... I'm really going to fight this annotation thing. All right, so you have your, it looks like a butt. My art skills are not the best. So when you have leads 1, come on. I can't. I really, like, white girl can't with this thing right now. All right, so we're gonna pretend that this is working because it's clearly giving me quite the fight. Nope. All right, so when you're looking at the heart rate, we talked about where the bundle branch block part goes down. So that where the electric current of the heart goes down is considered the septum, right? So when you're looking at the heart, right, you have leads V1 and V2. So leads V1 and V2 look at the septal wall of the heart, okay? And then as you move around, you have leads 3 and lead 4, okay? Right? So leads 3 and leads 4 are looking at the anterior wall of the heart. As you continue to move around, you have leads 5 and 6, which are looking at the low lateral wall, okay? Leads 5 and leads V5 and V6 kind of hang out with lead 1 and AVL, which are looking at the high lateral wall, right? So as you put the limb leads on, it comes across this way and looks at this part of the heart. So as it looks apart like this part of the heart, it's sort of a continual wall on that lateral side. Leads 2, 3, and AVF look at the inferior wall, right? Because they're looking essentially across the bottom and up from the feet. So if you have any sort of alteration in the way that the electric moves, usually, right, you're looking for elevations or T wave inversions. Really, elevations are your big primary looking, clue. This is how you're identifying what they're looking at. Does that answer your question a little bit? Okay. Yes, sorry. All right. I definitely have to restructure these slides because I think they're a little bit out of whack. But this is also how the textbook does it, and I'm like, anyway. So, hold on. This is one of my absolute favorite. I hate WebEx. One of my favorites, okay? This also tells you which coronary arteries you're looking at. So when you're looking at the heart, right? So you have, one more time, I'm going to see if I can annotate. Prepare to watch me be frustrated with technology. Maybe. Okay. So you have your anterior. It's not anterior anyway, so it's wrong. So septum. I apologize. Septum. Anyone ever hear of Sali, right? S-A-L-I. Septum, septum, anterior, anterior, lateral, 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 inferior. Oh, screw you, annotator. Inferior, inferior, okay? Now, if you look at the coronary arteries that are supplying, let's do, this is yellow, right? So you have, everything comes off the aorta. Really cool fact, your coronary arteries are actually behind the flaps of your aortic valve. So when the left ventricle pumps, the aortic valve opens, covering the opening to the coronary arteries. When the left ventricle is in diastole and refilling, those the flaps of the aortic valve close, which allows blood to backflow into the heart. If you guys are ever talking to a cardiologist and you want to watch their mind go a little bit, ask them if the coronary arteries ever experience systolic pressure. Because if they're filling during diastole, right, and your blood pressure is 200 over 100, the pressure inside the coronary arteries should really never experience the pressure of 200. However, if you have a patient who's extremely hypotensive, right, so maybe they're 50 over 20, they're only getting blood at a pressure of 20. Things to think about. Anyway, back to on track. So blood flows out right from the aorta, which we talked about. AVR is looking at your aorta. And as it comes out, it goes straight down the septum and the anterior wall of the heart right here, right? So it's supplying the left anterior descending, aka the widowmaker, is the no blip is the artery that is providing the blood to the major part of the heart, right? So it's providing it to the most of the left wall, because remember, when you're looking at the heart, that left ventricle is actually the anterior wall of the heart, okay? So the heart sits a little twisted where the right ventricle is behind the left ventricle, kind of more towards facing the spine, okay? So that left ventricle is facing forward, so you're getting that septum and that anterior wall right in the front. Then, off of the left anterior descending, which is why it's such an important artery, comes your left circumflex, right? So it comes and provides most of the blood for the lateral wall. Okay, right? So your lead 1, your lead AVL. Then, on the other side of the aorta, you have your right coronary artery. We were not super creative when we named these arteries. Thank God. Right? So that comes around the back and underneath, which is the the inferior wall of the heart. Okay? So collectively, these are your main arteries, and there's a whole bunch of other little tiny diagonal arteries that kind of filter in all over the place. But these are the 3 ones that you need to know, and you need to know where they supply blood to, like which parts of the heart. So if they say, oh, hey, you have a patient who's got elevations in leads V1, 2, and 3, which coronary artery is blocked, you can be like, left anterior descending, okay? Those are some example questions that you might see. Back to AVR really quick, or as I like to call it, the sad panda, because no one knows what AVR does, right? AVR is like over here, like we never talk about it. If you have elevation in AVR with diffuse depressions everywhere else, right? So like this is just looking like a tombstone, and then everybody else is like, hey guys, I'm a little sad. This is like either severe 3-vessel disease, which means like everybody's blocked, and this guy is going to probably need a cabbage instead of stents, or it's a full occlusion of the left main coronary artery, right? So like this part right here, when it comes right off the aorta, is the left main. No, I can't. I'm not fighting with this annotation anymore. Before it splits into the left anterior and then the left circumflex, okay? So that's like alarm bells should be going off that this is a very sick patient. It's also has the potential to be aortic dissections, okay? So if you have anything funky going on in AVR, just get to the hospital kind of thing. All right. Any other questions before we go back a little bit? Stop it. Cool. All right. A fight that you may or may not end up having with cardiologists is this VTAC or is this SVT with aberrancy, right? So you get those left bundles, your right bundles in there, and it starts to make everything look a little wide and funky. And when everything's wide and funky, we assume that it's VTAC, okay? One of the really fun things that we always did in my med class was whenever you were doing the dynamic station, VTAC always looked like a ghost giving you the middle finger, okay? That's kind of the vibe. It was just like a big tombstone with a little like meep off on the side. In order to determine if it's a VTAC, a good rule of thumb is, I like this one the most, is that all precordial leads are positive or negative, okay? If it's VTAC, they're all going in the same direction, okay? If you see, see right here how you have the normal R wave progression, right? So V1 is down, V2 is down, V3's got a little bit both sides, V4's got a little bit both sides, V5 and V6 are positive. That should be SVT, okay? Whereas you have, this one's a little harder to tell, where you have all of these down, 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 majority down, hard to tell, could be hard to tell depending. This is more likely to be SVT. You also will be more likely to have an extreme axis deviation, right? So we go back to looking at, is AVR going down or not? If AVR is positive, that's a warning sign that it's potentially VTach, okay? So just things to keep in mind when you're looking, okay? Or looking at EKGs. A lot of the times you're probably going to be pretty confident. If you have to Google your axis deviation rules in order to figure out like if this is or is not, right? Because an extreme axis deviation is going to be like, oh, hey, this is definitely VTach, then do it. But it's, again, not the biggest thing in the end of the world for you to know or not know. It's more important that you understand where the injury is and that you can identify the underlying rhythm. So, talking about injury, let's talk about ST segments. Any questions before we move into this portion? Okie dokie. So, T-wave changes are pretty consistent with new and acute cardiac events. And when I say T-wave changes, I don't just mean like they're upside down or they're elevated, but sometimes having symmetrical T-waves should be suspicious, or really funky looking T-waves, which is like DKA. We'll talk about that in a little bit. Remember back in your three lead lecture, or even in the textbook, it explains how the T-wave should be kind of like a gentle upward slope and then kind of a dramatic downward slope. If you have a very perfect round T-wave that's symmetrical, that can be indicative of some sort of injury or infarct going on. But don't read too much into it. Don't be like looking at every single EKG and folding the EKG over and trying to see how symmetrical the T-wave is. It's like one of those like, that's a really curious looking T-wave. It'll kind of give, like, again, your little warning bells should be going off. So if you see here in this picture, which is definitely taken out of your text, somebody's textbook, it might be the older textbook, as you, come on, annotate for me. As your patient starts to experience some level of injury to the heart, they're going to start experiencing different T-wave progressions. So you might never see this one, which is hyperacute. This is where we say, oh, it's symmetrical. So if you look, so see you have this like this gentle upswing and then it's like kind of dramatic downswing. Here, this T-wave is very, it looks like a camelback, right? So it's just very up and down, very perfectly shaped. In the few minutes to hours after the patient starts experiencing symptoms, that J point is going to start to go up, right? It starts to elevate. It starts to elevate, and that's when you get your traditional ST elevations, right? So this should not be all the way up there. It should be hanging out here at the isoelectric line. As this starts to progress, you might see what's called the Q wave, right? So this is a large, wide downward deflection that isn't normally there. So you see in this picture here, it's isoelectric to a QRS. If it's just a little itty bitty Q wave, like a smaller than a box, that's not pathologic. Okay, that's normal. Once that starts to get a little bit longer and a little bit wider is when it starts to be indicative of it being actually a sign of an injury. As the injury progresses, it will start to change the way that the EKG looks over time. So if this patient goes and gets like some stents in this range, this Q wave might resolve. This will go back to looking just like this over here, okay? If they don't, and trust me, there's plenty of patients who either A, don't notice that they're having a heart attack because they're asymptomatic, or those who are crazy enough to like be like, what is, and like they just let it go, they might end up showing what they call like these chronic Q waves, right? So they'll have these big Q waves. The isoelectric line might not be, it might have a little bit of an elevation remaining. This is because of that injured and or dead tissue, okay, that was never reperfused. Here's a kind of a progression of what this looks like. This is your traditional like STEMI, okay? Because you can totally have patients who will not present like this, who are having chest pain, who are having an NSTEMI or a non-ST elevation MI. That doesn't mean that you don't give those patients aspirin, okay? You know, patients who are like, you know, diabetic or female might not express the same dramatic looking EKG changes or symptoms, okay? So always have a certain level of suspicion for those things. I actually had a patient, I didn't have a patient, one of my students from my class had a patient who was an older woman, I think she was in her 60s, was complaining of dizziness, okay? That was it. No chest pain, no, you know, shortness of breath, just dizzy and fatigue, which, by the way, is the #1 symptom that women experience when they are having a heart attack, is dizziness and unexplained fatigue. And they did the 3 and they did the 12 because I teach my students always have a high index of suspicion. It takes 2 minutes to do in 12 lead, and she was having a STEMI. So just because the patient doesn't present quote unquote typically does not necessarily mean that they're not experiencing a true medical emergency. The problem with cardiac research is that it has primarily been done only on men. Because women are quote unquote too difficult to study because of menstrual cycles, which is really a load of rubbish because it's 2 weeks on, 2 weeks off. Like it's the hormones, the hormone cycle is very predictable. It's just people not trying hard enough as far as I'm concerned. So a lot of the research that they do does not actually include female subjects, which means that we really don't have a good comprehensive idea of the symptoms that women experience during this time. So 80%, I found in research studies like 80% of women will only experience, you know, inexplicable fatigue when they're having a heart attack. Just something to keep in mind. Always have a high index of suspicion to do the most for your patient. But back to this. So an NSTEMI is usually like it's a small little part. A STEMI is traditionally a transmural or across the wall infarction, okay? So whereas, hold on, let me see if I can annotate without breaking the thing again. Whereas a NSTEMI might just have like a kind of self-limiting area of damage right there, the transmural infection, it's a large enough artery that it will actually create damage all the way across the wall. And when you have damage all the way across the wall, you start getting these ST elevations. Now, the ST elevations are due to the fact that this quote-unquote dead zone pretty much creates like a mirror, or I guess not a mirror, but the EKG is, or the whatchamacallit, the lead, like, so like say this is V1, right, and it's looking at the heart, this is V1 and it's looking at the heart in this direction, it's going to see all the way across to this wall, okay? So the electrical activity of this wall is what V1 is showing you here in this elevation, okay? What was I saying? Nope, it's gone. So there is a progression between NSTEMIs, ischemia, and infarct. We're actually going to do this one first, okay? So when you have a patient who is experiencing ischemia, right? So ischemia is usually really reversible. So associate ischemia with angina, okay, right? You take your nitro and the pain goes away, okay? So you might have a patient who has maybe a little an ST depression, okay? They take their angina and it goes back to looking normal, okay? If you have a patient who's having an injury, this is when you start getting into your unstable angina areas, okay? This is where you get those the elevations, okay? Unstable angina, right? So unstable angina being chest pain that does not go away with the traditional treatments, or chest pain that starts in a non-expected way, right? So if you have a patient who's like, I have angina, when I walk up the stairs, I get chest pain, I sit down, it goes away. Now today they're like, I walked up the stairs, I sat down, and my chest pain didn't go away. You're here in the, okay, injury realm, okay? And then you have infarct, okay? Infarct is the muscle has died. It's dead. Call the priest, Dominoes and biscuits. It's going to have, you're going to have those pathological cues, okay? So there's a progression. And obviously injury, this ST elevation, can be resolved also. Usually that's when they do the stents. Sometimes they'll use heparin. Okay. Most of the time heparin is kind of resolved for the NSTEMIs. Okay, that's how they treat NSTEMIs. Or if you're going to go crazy, they might need a CABG, right? Which is a coronary artery bypass graft. Okay. That's where we're falling here in the injury. Ischemia, you throw a little nitro at it and it feels better. Here's another explanation, right? So you have a T-wave inversion here with ischemia, right? So you were like, that's a little funky right here, okay? And then it starts to move past, right? So this is usually okay. This is usually switched. Excuse me. Another thing that you might see during your EKG experiences are what they call early repolarization, or what we call early repolarization. You usually see this in younger men, women too as well, but usually younger men, where they will have what looks like elevations, but the J point then kind of comes down into like a squiggle right before the T wave, right? So when you're looking at between the J point and the T wave, if it looks like a happy face, right? So it's making, this shape, it's usually early repolarization, okay? If it's doing this one, it's a sad face or a tombstone, it's always a fun, right? Then this is more indicative of an injury or infarct or ischemia, okay? Fun little side note that you're not going to need to know, De Winter's rule. Basically, if you have a really, really crazy looking T wave with a depressed J point, this is a ischemia or a STEMI mimic. Not mimic, it's another STEMI concern, okay? You may or may not see these. Just something to throw in there, right? If the general rule is if you have a patient who's experiencing chest pain, even if they have a normal EKG and that chest pain cannot be attributed to something, for example, like trauma, it is a good idea to give them aspirin, okay? just do remember that New York State has changed the amount of aspirin from 162 to 324 as the official across the board. New York City was doing 162 for a while, but they've decided to finally get on board with everybody else in the terms of aspirin. If you have a patient who is has a left bundle branch block or a pacemaker, they have something that's called Sgarbossa criteria. Sgarbossa criteria is what I remember saying before, where you have a QRS that a left bundle branch, right, a really broad QRS, and then the T wave goes in the same direction. That's one of Sgarbossa criteria. Okay, or it's called concordant. But in order for this to be considered a STEMI equivalent, you need to have 3 or more points. So ST elevation in a lead with an upward QRS complex, so you got your funky looking EKG, and then you have a T wave that's going in the same direction and it's elevated a millimeter above the isoelectric line is like the biggest clue. Couple other things. Again, you're really not going to need to know this. This is something I'm just throwing out for you. So like if you want to look into it more because you're interested and you're feeling confident in 12 leads, go for it. If you are like down the road, like decide you really like doing cardiology and you want to look into this as well after you're a medic, it's knock yourself out. It's a lot of fun. Here's a picture. This guy Smith modified it to some other criteria. But again, not something that you're really going to be held to for this class. It's just important to know. All right, so back to this real quick. We kind of grasp the locations, right? This is probably one of the most important things you can take away from 12 leads in this 12 lead lecture. When you start having elevations on one side, remember I said like when you have that STEMI where it's across the wall and you're looking through the dead tissue to the other side, the EKG has what we call reciprocal changes because you're looking across it to the opposite side. So, hold on, let me set up a little. Here's your 12 lead. All right, so you have yes. Let me know when you're good. Any other questions or concerns before, well, Dan copies this down? Thanks. All right, so here we go. 12 lead. Right, so we have your septum, anterior, lateral, inferior. This is right down here. This is really lateral is probably your most important. So, if you have a patient who's having an injury in the lateral wall of the heart, the opposite of the lateral in cardiology terms is the inferior. So if you have a patient who's got ST elevations in, any of those lateral leads, right? So V6, V5, V6, leads 1 or leads AVL, you're going to have a reciprocal change in the opposite side of the heart, right? Because you're looking through that dead tissue and it's going to look like the opposite. Okay? Think of it as sort of like the Bizarro realm, right? So all of a sudden Spock shows up and he's got a mustache and you're like, what's going on? It's completely the opposite. So where you're having elevations in one side, you're going to have depressions on the other. And this is a confirmation kind of thing. So if you have a patient who you think they have like these elevations in leads, 5, 6, 1 in AVL, and there's no reciprocal changes, right? You don't have depressions in the inferior walls. It might be an early repolarization, okay? Doesn't necessarily mean you're not going to send it to telemetry and be like, hey, can you confirm this? Because elevation is an elevation. So if 2, 3, and AVL are elevated, you would expect to have depressions in your lateral leads, right? V5, V6, lead 1, and lead AVL. Now, assume that you have depressions in leads 1, V1, V2, V3, and V4. What would the opposite side of the heart be? What's the opposite from your front? Nobody? Bueller? All right, it's the posterior. I don't know if y'all are just not unmuting or failing at chatting. We do not regularly do posterior 12 leads, right? But you can. If you have a patient who has depressions in leads V1 through V3, you're going to take lead 4, 5, and 6, and you're going to move it around to the back of the patient for lead 7, V7, V8, and V9. If you have a patient who has depressions like this, see, V1 and V2 have these weird, funky depressions, you can confirm that they're having a posterior MI if you put the leads V7 through V9 on and run the 12 lead again. The only thing you need to keep in consideration for that is that if you print out another 12 lead, it's still going to read leads V4, V5, and V6. Okay, so when you print it out, make sure that you cross that out and write 7, 8, 9. It's just a good thing to do. It's a way to be thorough. Other things, if you have an individual who you have some depressions, or you have some funkiness going on in leads like V1 and V2, or you have a patient who's extremely hypotensive, what you're going to do is you take lead V4 off. So, right, you have like V1, V2, V3, V4, V5, and V6. You take V4 off and you move it over to the same spot on the right side, which is mid-clavicular, right under the nipple. And then you run it again, right? But again, make sure that when you run the EKG that you write V4R on it so that you know what you're looking at. If you have an individual who has elevations in V4R, this means that the right ventricle is involved, okay? What happens if you give a patient nitro with a weak right ventricle? Oh yes, they do. They bottom out pretty hard. This is like if you have a patient who you have elevations in your inferior leads, you want to check, right? You want to check your V4R to see if there is right ventricle inclusion. Okay, so lost my train of thought real quick. I know a lot of the times they're like, oh, if you have a patient who has an inferior wall MI, don't give them nitro. That is false, okay? If you have an individual who has a inferior wall MI going on, right? So you have elevations in lead 2, lead 3, and lead AVF. And then you run the EKG again and put V4R on, and there's no elevations. You are good to give them nitro, again, assuming that the patient is not already hypotensive. Good point of note, if you can get an IV before you give a patient nitro, it is good practice to do so. Because if you do bottom them out, you can fix it. It's so much better that way. Yeah, okay. Just keep those things in mind. So let's look at 2 12 leads really quick. And I want you guys to unmute for this because I want to know where is the infarct, or where is the MI? Where's the MI, guys? Yep, anterior, right? So what else? Where else? What else is involved? Perfect. This is an anterolateral MI, right? So let's just label everything again, just for consistency's sake. Septum, septum, anterior, anterior, lateral, 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 inferior, inferior, inferior. So, let me see if I can change colors without breaking the annotated. So you see here, here's your isoelectric line, right? And here's your J point. Just draw a dot, you mother. All right, right? So your J point's all the way up there. That is a significant distance from where it's supposed to be. Okay? So you same here. You have there, and there's your... Now, remember we were talking about reciprocal changes. Here's your iso... Stop it. Here's your isoelectric line. Here's your J point all the way down there, right? So you have that depression in the T wave right down there. Here it is again in the lead AVF. It's a little harder to see here in lead 2, right? It looks almost normal here. While this is an anterolateral, there is some septal involvement, right? So just don't forget that bad boy's there. Okay, follow-up question. What coronary artery? Yep, LAD, right? So your LAD goes this way. What else? What branches off the LAD? Remember this part of the picture? Yes, left circumflex. I swear it looks like I'm a small toddler with crayons. So your left circumflex and your LAD is involved. More accurately, it's probably something right along where that bifurcation is, which is why it's so extensive, right? Because the left circumflex branches off of your left anterior descending. Good. One more. Maybe, if me and Annotate get along today. There we go. All right, where's your MI? Perfect, perfect. Right, we all see here in our inferior leads, right? So let's label it again just for consistency's sake. Septum, septum, anterior, anterior, lateral, 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 inferior. Okay, so here it's hard to see in lead 3, but in leads 2 and AVF it's a little easier. Here's your isoelectric line. There's your J point. It's hanging out nowhere near where you want it to be, right? Again, down here, isoelectric line, J point. Not exactly where you want it. You see, you can't really see. You have a little bit of like an elevation here, a very smidgy one in the lateral leads. So I would even call this is, if you look at the shape of these T waves in the lateral leads, they're kind of symmetrical. Okay, so it's approaching, there's some damage here. Now, what's your coronary artery? Perfect. RCA, right? And going back to that picture from before, just to keep continually to jog your memory, right? We have your aorta up here, and then that right circumflex comes around this way. Not right circumflex, just the right coronary artery, excuse me. Okay? Awesome. Awesome, awesome. Stop share. So, how are we feeling, guys? It's a lot. EKGs are a lot of information. Questions, thoughts, concerns? Y'all are a quiet bunch. All right, so as I said, don't worry too much about axis deviation. It's good to know. It's good to review after you kind of understand the primary goals, which are really, I want you to focus on identifying where the injury is and what artery is involved. Those are really the most important. Also understanding that you still need to identify the underlying rhythm. Okay, so sinus tach, sinus Brady, not bundle branch, heart blocks, right? You need to understand that what those are, because you still will have that in a 12 lead. Because you might have a patient who's in a 3rd degree heart block and having a STEMI. Okay, so just make sure that you kind of master the rhythms so that when you come and look at it in the 12 lead component, you'll have a little better grip. No questions. I know that Maria posted a bunch of 12 leads up on the JB Learning site. I would highly recommend you guys going and looking through them and kind of practicing, identifying what's, an elevation, what's a depression, and your reciprocal changes. Okay? All right. Well, if no one has any questions, no? No? Bueller? All right, guys. Good luck. Have a lovely day.